today to complete the conditions of the respiratory disorder that may find in the newborn. The last condition regarding the respiratory disorder, pneumothorax. Pneumothorax, by definition, is the presence of the air in the pleural space. And the most serious one when the air often is under pressure. And this setting is referred as a tension pneumothorax. Tension pneumothorax. Incidence and etiology in the neonate. Of course, asymptomatic spontaneous pneumothorax occur in 1 to 2% of otherwise a healthy newborn at birth. Symptomatic pneumothorax more commonly occur in the infant who is receiving mechanical ventilation or who has underlying lung disease, for example, respiratory resistance syndrome or meconium aspiration syndrome that we talked about this condition before. What are the clinical presentation of pneumothorax in the newborn? This is the most important, especially when the air push the mediastinum to the other side, tachypnea, and elevation of the affected hemothorax. Important point to auscultate the chest. We have a localized diminished air entry on the affected side. Diagnosis, chest radiology, important to demonstrate a dense, partially collapsed lung surrounded by a large area of radiolucent air within the hemithorax. So we have a loss of the lung tissue on the affected side. And depending on the degree of tension and the lung compliance, the mediastinum structure are shifted toward the opposite side of the chest. We can use another tool of investigation regarding pneumothorax. Translumination of the thorax may aid in the diagnosis of the pneumothorax in the emergencies, of course. Positive evidence is the transmission of the light through the affected side because there is no lung tissue at that side. So this maneuver can be used as an emergency tool for diagnosis of pneumothorax because such symptom so severe that necessitates immediate intervention. Thorax, you can see the left side pneumothorax and this side displacement of the mediastinum to the other side. So this is a case of pneumothorax. Therapy, as we say, the severity of the newborn depends on the amount of the air tension on the lung. If no other lung disease exists and there is a minimal respiratory distress, supplemental oxygen for several hours usually so enough. But if we have a significant degree of tension, respiratory distress, or some other lung disease exists, the air should be evacuated out by aspiration with the syringe and needle, or by insertion of the chest tube if a continuous air leak exists. Of course, needle aspirate done as an emergency action, and a definite, of course, insertion of the chest tube. Of course, at this point we finish the common respiratory problems involving the newborn. Now we shift to the other part of disorders, that the digestive system disorders in the neonate. An important part of this, speaking about neonatal necrotizing enterocolitis, NEC. What we mean by this condition? It's a spectrum of varying degrees of acute intestinal necrosis with secondary invasion and devitalization of the bowel wall. So, the intestinal wall vitality start to be decreased, that end with necrosis of the bowel. After necrosis, we have a secondary invasion by different microorganisms. Incidence of NEC, of course, it's a serious and a common problem, affecting up to 5% of all newborn admitted to the intensive care units. Of course, this is percentage not from all live birth. 1 to 5% of infants that admitted to the intensive care units, not from all. Affected infants most commonly are premature. So NEC can add it to the conditions that mostly affect the preterm rather than term infant. Asphyxiated and suffering from other medical problems, necrotizing enterocolitis rarely observed in a healthy term infant, and less common in infants that on breastfeeding. So breastfeeding should just breastfeed because it's protective against NEC. Etiology and pathogenesis of NEC. Bowel ischemia second to the preceding perinatal asphyxia generally is regarded as the cause of bowel wall injury. So if we have a bowel wall injury with aggressive production of formula of human milk, then provide a substrate for bacterial overgrowth. Bacterial invasion of the bowel wall, often with gas production, that give us pneumonitis intestinalis finding on X-ray film. Of course, in severe cases, pneumonitis intestinalis may lead to the necrosis and perforation of the bowel. As we say, NEC rarely to be occurred in the full term, a healthy newborn. So what are the factors that predispose for such condition? Premature prematurity with perinatal structure, systemic hypotension, patent ductus arteriosus, placement of the umbilical artery catheter, because the catheter should be inserted in umbilical vein rather than artery. Extra transfusion is important factor for NEC because we are commonly doing such operation. So keep this possibility after external transfusion. Previous treatment with systemic antibiotics, use of hyperosmolar formula, and rapid advancement of the feeding volume. All of these should be raised the suspicion of NEC. Keep in mind, please. Clinical features. Signs and symptoms are usually noted during the first 2 weeks of life. Of course, shortly after introduction of feeding. So, what are the clinical that raise suspicion of such condition? Gastric acidity, which often is bile stain, abdominal distension, and even erythematous changes on the abdomen. Poor perfusion with hypotension or shock, abdominal wall discoloration, and stability of the temperature with metabolic acidosis. Laboratory findings of NEC, of course, suggestive and not diagnostic blood film leukocytosis, neutropenia or thrombocytopenia, suggestive or the finding on the radiograph include dilated thickened bowel lobe in the right lower part, perforation with the presence of free abdominal air and portal vein air. So important to send for X-ray. This X-ray and the arrows direct you to the presence of pneumonitis intestinalis, which of course indicate NEC, Clinical courses of the NEC. Of course, most of infants follow a course characterized by feeding intolerance, abdominal distension, occult blood stool, dilated bowel. These findings improve rapidly with therapy. So this is a mild course that most of these patients improve with treatment. The other group that have a severe course with progressive symptoms, including gross blood in the stool, extreme abdominal tenderness, hypotension, DIC, and sepsis. Pneumonitis intestinalis and perforation frequently occur in this setting. So naturally, we do courses, mild and aggressive course. Treatment. Treatment should be begun with discontinuation and the administration of intravenous fluid. Once culture has been taken, systemic antibiotics, especially the combination of the ampicillin plus gentamicin should be given. Also, any accompanying disorder like DIC and others should be treated accordingly. Role of surgery may be important in advanced cases. So, necrotic bowel segment is indicated, and for infants who are progressive bowel, so progressive downhill course, and for those in whom intestinal perforation has occurred. Of course, it's important in advanced cases in spite of its complication later on. So if these infants survive, most of them complain from side symptom of short bowel syndrome. Prognosis: the mortality rate associated with necrotizing enterocolitis, which is highest in the most premature infant, and reach about 30%. Later complication may include intestinal structure and short bowel syndrome So important condition and EC, simply that happen or involve most of the newborn, premature newborn, that may suffer from other medical conditions with aggressive introduction of the formula. So if this happens in the premature, the suspicion of an EC comes to your mind, and then start with immediate treatment with stoppage of the feeding and adding of antibiotics beside intravenous fluid. Now, we proceed for another important subject regarding newborn. Of course, anemia of the newborn. This type of conditions involve both term and preterm newborn. Generally speaking, neonatal hemoglobin concentration immediately after birth about 16 to 18 grams per deciliter. After birth, the hemoglobin should be get down and decline up to 11 to 12 grams per deciliter, especially at 6 months of age or term, and earlier than this in a premature. The structure of hemoglobin, of course, differ in the newborn from that in adult. Here, after birth, fetal hemoglobin represents 6 to 90% of hemoglobin. Of course, and the level decline up to 4 months. At that time, the hemoglobin structure like adult. For term infant, blood volume around 90 ml per kg, and preterm may reach 100% per kg. Sometimes you hear about physiological anemia of newborn. So from its name, physiological anemia, it happened according to the certain physiological process that happened immediately after birth. And of course, as it's physiological, the newborn term and new term and preterm can accommodate themselves with this type of anemia. physiological anemia is noted at 2 to 3 months of age in the term and in 2 months of age in the preterm. So preterm suffer more because the storage of the preterm less than term infant. Of course, the storage of the substrate of hemoglobin, the iron, less than in preterm, less in preterm. It's a normal process that does not result in sign and does not require any treatment, just observation. It is a physiological condition believed to be related to several factors. So, what are the factors behind this physiological process? The excessive tissue oxygenation experience at birth, short and low erythropoietin levels, low erythropoietin levels. The most important in a lot of newborn that we call hemolytic anemia of the newborn. Hemolytic anemia of the newborn. From its name, we have different degrees of hemolysis that newborn, term or preterm suffering from. Other name, we can say erythroblastosis fetalis, the same meaning of hemolytic disease of the newborn. Which that may result in hemolysis in the newborn, besides others, but the most common result from blood group incompatibility between the mother and the fetus. Hemolysis occurs when the maternal antibodies start to particular blood group to the fetal red blood cells, which are then destroyed in the spleen. So, the maternal antibodies that transfer through the placenta to the blood of the newborn, and these antibodies consider the RBCs of the fetus as a foreign body. So we have a reaction between antibody and antigen, of course, and then destroy of the RBC that relating by spleen. ABO blood group incompatibility, important subject as we say. So the neonatal hemolysis develops only if the mother had IgG antibodies from a previous exposure to A or B antigen. So presence of antibody in the blood circulation of the mother, important part for such process. So these antibodies cross the placenta by active transport and if the mother to a fetal antigen may have occurred by previous transfer or by condition of pregnancy that results in transfer of the fetal erythrocyte into the maternal circulation, portion during pregnancy, amniocentesis, or even normal delivery. So, transfer of erythrocytes, RBCs to the maternal circulation make the mother forming of a lot of antibodies that again may cross the placenta to the fetus and cause as such destruction. ABO incompatibility generally, when sensitization happens, usually does not cause a fetal disease other than mild anemia. It may produce hemolysis of the newborn, however, which is most as significant anemia and jaundice. So because many mothers who have blood group O have antibodies to A and B before pregnancy. The firstborn infant of A or B type may be affected. So if we have a mother with a group O and the fetus group A and then group B and then group AB, all of these, of course, consider ABO incompatibility. In ABO incompatibility, the firstborn affected and the next pregnancy start to be less in severity. Of course, this in contrast, the RH negative disease to RH negative disease hemolysis with ABO incompatibility is less severe than hemolysis in RH sensitized pregnancy. Why? Because the anti-A or anti-B antibody may bind to non-erythrocytic cells that contain A or B antigen. So this helps in dilution effect on the number of antibodies. Another cause? For such phenomena, fetal erythrocytes have a fetal A or B antigenic determinant than they have RH negative mother cells. With declining incidence of RH hemolytic disease, ABO incompatibility has become the most common cause of neonatal jaundice requiring therapy. Please keep your attention regarding this idea or this information. ABO incompatibility has become the most common cause of neonatal jaundice that requiring therapy. Because the most common cause of neonatal jaundice is physiological, that not need therapy. But jaundice that need therapy commonly caused by ABO incompatibility. The most common cause of jaundice that not need therapy is physiological in nature. Arthroplasmosis fetalis or hemolytic disorder classically is caused by RH group incompatibility. Most RH negative mothers have no anti-RH antibodies at time of their first pregnancy. So the first pregnancy free from antibodies. In most RH sensitized cases, the D antigen of the fetus sensitized the RH negative mother, resulting in IgG antibody production during the first pregnancy. So D antigen that happened resulted from crossing of the erythrocyte of the fetus to the RH negative mother that make these mother sensitize and produce antibodies. Because most mothers are not sensitized to RH antigen at the start of pregnancy, RH incompatibility is usually a disease of the second and subsequent pregnancy. The first affected pregnancy results in antibody response in the mother which detected during antenatal screening with Coombs test. So, important to define the mother who are sensitized for the antigen of the fetus. You should send for Coombs test. You should send for Coombs test. Because if Coombs test positive, it means the mother sensitized and of course not benefit from the introduction of anti-D that usually effective in non-sensitized mother. The first affected newborn may show no serious fetal disease and may manifest hemorrhagic disease of the newborn only by development of anemia and jaundice. Subsequent pregnancy results in increasing severity of the response because of earlier onset of hemolysis in utero. So, severe hemolysis results in fetal anemia, heart failure, elevated venous pressure, portal vein obstruction, and albuminemia, resulting in fetal hydrops. Fetal hydrops, of course, characterized by ascites, pleural effusion, pericardial effusion, and anisarca. Of course, the risk of fetal death is so high. So, erythroblastoma fetalis resulting from RH may be mild in the first pregnancies and may result in severe anemia and heart failure. In this case, with severe hemolysis, if the fetus in utero can be delivered and treated in neonatal intensive care unit, but if the fetus less than 33 weeks gestation and immature lung, intrauterine transfusion or negative blood into the umbilical vein is indicated and may have to be repeated until pulmonary maturity is reached. So, follow-up of RH incompatibility methods important for you because you decide at which time you start to deliver the treatment to save the fetus. Prevention of such disorders. In fact, RH incompatibility, so important subject. Why so important subject? Because completely preventable condition. So prevention of sterilization of the mother carrying RH positive fetus is possible by treating the mother during gestation. Can be given, of course, at 28 weeks of gestation and even after birth within the first 70 hours of birth. So, anti-D, immunoglobulin, anti-D in a dose of 300 microgram is based on the ability of this amount to anti-RH positive antibody to bind all the possible fetal RH positive erythrocytes entering the maternal circulation during the fetal to maternal transfusion at birth. So, giving of this type of medication to attack any erythrocytes from fetus that enter the mother circulation, and so we have antigen antibody reaction then removed by spleen. Most of the amount of the blood that transferred from the fetus to the mother in about 30 ml and 30 ml. So 300 microgram, so enough to deal with such amount, More amount may need more anti-D and more than 300 microgram. Diagnosis and management. Hemolysis in utero result in hydrops and sarca, heart failure, pulmonary edema that result in asphyxia, hepatosplenomegaly, pallor, and become jaundice within the first day of birth. Of course, this presentation in severe hemolysis in RH incompatibility, while patients with ABO incompatibility often are asymptomatic and show no physical sign at birth. Mild anemia and jaundice develop during the first 24 hours up to 72 hours of life. This presentation of sarca, heart failure, hepatosplenomegaly can be compared with the newborn that suffer from acute blood loss due to fetal-maternal hemorrhage, placental previa, or internal hemorrhage by acute pallor, diminished peripheral pulse, and shock, but without hepatosplenomegaly. All the time, hepatosplenomegaly indicate chronic process that follow RH incompatibility in utero. Newborn with chronic blood loss caused by chronic fetal maternal hemorrhage, twin transfusion, present with marked pallor, heart failure, hepatosplenomegaly with or without hydrops, with low hemoglobin at birth, with decreased serum iron store. Shock is more typical in patients with internal hemorrhage, whereas in hemorrhagic disease, heart failure may be seen with severe anemia. So these sign symptoms differentiate from the chronic process from acute process. Shock, of course, follows the acute process like hemorrhage, while severe anemia follow chronic hemolysis. Laboratory finding of complete blood count, blood smear, retic count, blood type, and direct Coombs test This, of course, consists to detect presence of antibody-coated RBCs. All of these should be performed immediately after birth. We can send for RBC enzymes, hemoglobin electrophoresis, and RBC membrane test. The diagnosis of fetal maternal hemorrhage is confirmed by clear big acid elution test, so important to differentiate the maternal from the fetal hemoglobin, depending on the fetal hemoglobin, because fetal hemoglobin is alkaline in nature, while maternal acidic in nature. So the base of this test depends on this phenomenon. Maternal hemorrhage, or when non-immune hemolysis is suspected, ultrasound of liver, brain, spleen, or adrenal gland may be indicated. The treatment of symptomatic neonatal anemia is by, first, transfusion of cross-matched packed RBCs. If immune hemolysis is present due to RH or IBO, the cells to be transfused must be cross-matched against maternal and fetal plasma. Acute blood loss may need non-blood product such as saline if blood not available. To correct anemia, we can use 10 to 15 ml per kg of packed RBC, and then, of course, follow and treat according to the next complications. Of course, the hemolytic anemia, so important. Why so important? Because it results from so unknown risk factors, and of course can be prevented by adding simple treatment injected to the mother at the end of the second trimester, or even after birth, by anti-D for mothers that are diagnosed as RH negative with RH positive newborn. Anti-D not needed to given to RH negative mother with RH negative newborn. We should have RH incompatibility, but if the mother and the newborn the same RH, no need for extra treatment, because the hemolysis don't happen or maybe happen with with mild anemia and jaundice. Anti-D is an important drug to antagonize the antibodies, to antagonize the antigen that represented by fetal erythrocytes and then destroyed and get out from the maternal circulation. Anti-D should not be given to the sensitized mother, Our job in this preventable condition to prevent the mother from formation of antibodies to the RH negative fetus. To the RH positive fetus. So important to prevent and deal with such important condition. Any question, please?